Welcome to Paget's Awareness Day 2026. I'm Professor Stuart Ralston. I'm chairman of the Paget's Association. And the theme of Paget's Awareness Day this year is pain, which is the most common or of symptom in Paget's disease. Now, today I'm joined by Professor Lesley Colvin, who's a professor of pain medicine at the University of Dundee and a specialist in this area. Welcome, Lesley.
Thank you.
Okay, well, as I said in the introduction, Lesley, pain is the most important symptom or common symptom in Paget's disease. And I did another interview as part of Awareness Day this year with Catherine Berg and Derville Dockrell, who I think you probably know. And they
Mm.
were explaining that when they tested sensation in the skin over bones affected by Paget's disease, it seemed heightened compared with, normal skin, as it were, using a technique called what they called QST. Can you explain a bit what QST is and what that might mean? Over to you.
Yeah, so QST, it stands for quantitative sensory testing, which is just a long way of saying that it's a repeatable way to try and measure how we feel things. And so it's not just pain. So we check sensation, including light touch, warm and cool temperatures, and then pinprick is the kind of very basic quantitative sensory testing. Um, And the idea is that you can compare sides, so see if there's a difference, if there's a sore area to another bit, or you can compare against other individuals of a similar age and gender.
Okay, thanks. And this difference that they noticed, um, I know from speaking to them, it wasn't necessarily in people who actually had pain at the time. How might that come about? Can you try and enlighten me and the audience that may be listening to this today?
I think the important thing to remember is that our pain system is dynamic, so it's changing all the time in response to the input from our environment. So if you have had damage, for instance, to bone from Paget's disease, then the pain fibers round about that area will change and they'll send different messages. But the change isn't just round about that area, it might be anywhere in the pain system. So from the bone, the nerves carry the messages up to the spinal cord and then up into the brain. And at every bit along that pathway, there's the potential for things to change, and it's continuously changing and being remodeled. So it changes depending on what you're doing, depending on what the Paget's disease is doing, and also potentially depending on what treatment or interventions and ways you're managing, and that can also change it. Um, because I think one thing that's important to remember is that as you're sitting in the chair now, your brain will be bombarded by thousands of little messages telling you that you're sitting, that there's temperature changes, that your clothes are maybe moving, and you're able to concentrate on what you're saying to me today because your brain is dampening down that input. And what we often see in chronic pain is that dampening down, so the top-down regulation also changes. So it's not just what's coming in from the area of damaged bone, but it's the way that our brain has learned to respond to that. And we become less able to respond to that dampening down. So people with chronic pain often say that they find it hard to concentrate on doing things. And part of that is because those messages that are normally dampened down so that we can concentrate is that system is not working properly.
Okay, very interesting. Now, I know that your practice is quite a wide practice. I know that you previously published in people with like bone cancer, for example.
Mm.
And do you see similar abnormalities in that situation? And I guess what you're saying is because the bone is abnormal, it can affect these pathways. Yeah. What are your thoughts?
Yes, so there's lots of different types of pain. There's acute pain, which just is necessary, it's essential. So you need to be able to feel pain to protect yourself. And there are some quite well reported families that have inherited congenital insensitivity to pain. And I remember when I was training as a junior anaesthetist and working in the sick kids hospital, they would come in having damaged bits of themselves because they can't feel pain. Whereas in chronic pain, that is something that you don't want. It's when the pain system goes wrong.
Okay. So pain can be a good thing, but it can be a bad thing, as have you said, if it goes wrong.
Yeah. So it's not like some chronic disease conditions where you just don't want that condition. You can't get rid of pain completely. So, before I started training, actually, so last well into last century, there was people would just cut nerves because you think, oh, you get rid of the pain. But actually, that's not good because you then can't feel the area that the nerve supplies. You're not sure where it is in space. You maybe not be able to move it properly. So yeah, we need to be able to feel pain, but we can't just get rid of it. So
Okay.
that's a bit of a kind of challenge when you're treating it.
Okay, thanks. Now, as you may know, in Paget's disease, one of the treatments that doctors use are bisphosphonate drugs, and that kind of turns down what we call the abnormal bone remodeling in the disease, and we know
Yeah.
that sometimes they work really well, but not completely sometimes, so the response may be incomplete. So, could these abnormalities that you've just described that may occur, could that explain this incomplete response? And um, is that something we could think about when we're treating the pain?
Yeah, I think you've highlighted a really important point, Stuart, that so the bisphosphonates work well in some people and
Mhm.
not so well in others. And the question is why is that? So maybe it's because in the person where they work well, they're working the pain is very much maintained by what's happening with the activity in the bone, which are dampening down with the bisphosphonates. And maybe in the people where it doesn't work so well, what's happened in the pain system, that there are changes way upstream of that, so in the spinal cord and up into the brain, which the bisphosphonates are not going to affect at all. So that's a challenge when you've got someone coming to see you in clinic, is that, if you give everyone bisphosphonates from the start, there's a group of those that are not going to respond well in terms of their pain control. And
Okay.
that's where things like quantitative sensory testing, the QST, might be able to help us direct treatment better. So that by beginning to understand the mechanisms that in the individual that you're seeing in clinic, are those peripheral mechanisms maintaining the pain, or are the central mechanisms maintaining the pain? And then if it's a central mechanism, you think, well, bisphosphonates are probably not going to work that well. We're going to have to try something else that targets what's happening centrally.
Okay.
And I could, there's an example of that actually there's a research study which is quite old now. It's 2014. It was published. It was looking at diabetic neuropathy, so pain from diabetic neuropathy. And they used quantitative sensory testing in all the people who were coming into the study to try and understand the mechanisms that in each individual patient. And then they analysed the results. So if you looked at just the whole group of patients overall, so averaging everyone together, no one is average, but that's what we do, we average everyone together. And the number of patients that you needed to treat for one of them to get a reasonable benefit was about 8 patients, which is okay, but it's not that
Yeah.
great.
Okay.
If you then divided it up from the drug that was being used was a drug that blocked a particular channel, a sodium channel, and that was probably peripheral. So it changes around about where the pain has been generated. And if you divide it up into the group who probably were those channels are very active and those who weren't, and then you analyze it differently, in the ones where the sodium channels are very active, the number of patients that you needed to treat to get a good response dropped down to almost 1 in 2. So it's much better. And whereas the number of patients with the sodium channels were not that active, the number of patients you needed to treat almost doubled them up to about 16.
Okay.
So, and that actually is that kind of, I know it's a different condition, but it's the key to saying actually, rather than just saying, oh, you've got pain, we'll give you this drug, is trying
O-
to work out what's the mechanism.
Okay. So that's very interesting. It's kind of like a what they call a personalized medicine based
Absolutely.
on the results of these investigations. And obviously as a pain specialist, you will be using a lot of these drugs that might target nerve fibers. Um, and maybe along with bisphosphonates. So, is there anything new in that? Any new drugs? I know that cannabidiol has really gone into vogue in people with pain and other conditions. Any thoughts on those kind of things, Leslie?
Yeah, sure. So the new updated sign guideline on chronic pain, the first half of it was published last week, actually. And within that, we looked at the evidence for medicinal cannabis, which you mentioned and is very topical. Um, I can't remember if there's any specific studies on Paget's disease, but there's a lot of studies published. The evidence overall, and we did a big analysis of all the evidence that's been published, is that the effect, the benefits from it are pretty small and not likely to be clinically important at an individual level. Whereas the harms, and there's not good studies looking at longer term harms, but even looking at short term harms, the harms were quite high. The risk of harm was high, and that was things like confusion, sleepiness, negative effects on mental health. So not insignificant effects. So that recommendation that we've made in the new SIGN guideline is that we shouldn't be using medicinal cannabis out with the context of a clinical trial. It's not that
Okay.
it doesn't work. And I certainly get patients coming to see me saying that it works for them. But my real concern with new things as they come out, such as medicinal cannabis, is that unless we do the trials properly, we can cause harm. And we saw that with opioids 20, 30 years ago, where opioids were used very widely and caused a lot of harm, a lot of deaths.
Mhm.
Um, and when you actually look back at the evidence wasn't there. So I think we have a responsibility as a medical profession that if we're going to recommend new treatments, that actually we have robust studies in place to make sure that we're not going to harm people, because pain is so awful that a lot of people that I say they would take anything to try and help.
Sure.
Yeah.
Yeah, actually, congratulations on the sign guidance. I actually read it in advance
Good.
of this
That's nice.
in advance of this interview, and it was a huge amount of work. And as you say, that was just part one.
That's
So
part
it,
one. And yeah, and part two, we're also looking at dietary interventions
Mhm,
and alternative therapies because, again, although they're not routinely prescribed by GPs, there's something that people with chronic pain use and potentially spend a lot of money on, actually,
mhm.
to their detriment. So trying to understand whether there's benefit in that or not is important. And one of the issues is the quality of the studies that have been done. Um, I won't preempt that next version of the
Okay.
science guideline, but I will say that there's potentially some evidence of small amounts of benefits from a few of the dietary supplements. Um, Alternative therapies, again, potentially evidence for short-term benefit for acupuncture, but not long-term benefit. So, but I'm not going to preempt the
Okay.
publication of that.
Thank you,
But
Leslie. We will respect that. And but maybe we should get you back to one of our information days, and you could enlighten the audience in this. Well,
yeah,
look,
can I say one thing actually, which
yeah,
is another sneak preview from the next phase of the sign guideline,
yeah.
is that of all the interventions that we've reviewed the evidence for, the one that seems to be coming out as most positive with least harm is increasing physical activity
Okay,
across the
okay.
board. Um,
Interesting, interesting. Well, look, Leslie, thank you so much for taking time out of your schedule to speak to me. I've learned a huge amount today from you, and I've found it very enlightening. And hopefully, others that who will who have listened to the podcast or the video today will also too. So, thanks once again.
Thank you. Thank you for giving me the opportunity.